احنا لما كنا في الكي في الحقيقه في السعوديه علاج السي اف كله بيتعمل اي دي اف، كله بيتعمل بري امبلانتيشن تيستنج بناء على ريبورت على الفيروس. وبعدين انا لما جيت في مصر افتكرت ان الكلام ما بيتقالش في مصر الحقيقه. الكوميونيكيشن مع وحده الجينيتكس عندنا في عين شمس واعتقد هتكون موجوده كتير، لا يقدر يتعمل.
كل البيرنتس بيوافقوا عليها تدخل بقى في البيت علقوا وبعدين خلي بالك من الام اللي هي شي مادر سايز يعني لاند جو اوف بيبي، دي بقى قصه ثانيه خالص. يعني
هو اتليست يا مالي لو الام عندها هيستوري 2 أو 3، احنا عندنا في عين شمس ام والاستاذ بروف عارفاهم ام عندها 2 و3، فدي لما تفكر في طفل تاني ما يوقفش.
انا الاول بحب اشكر دكتوره ناجي على المجهود الرائع اللي عاملاه في الوحده، وشكرا للتيم على الاسبوع الجميل المثمر دوت اكثر من رائع. دكتوره ناجي شكرا دكتوره ساميه ويوب تيم على المجهود خلال الاسبوع ده، استفدنا جدا جدا ومواضيع كلها كانت مبهره وجميله. دلوقتي الدكتوره ساميه والدكتوره ماجي هتكلمنا على السي اف تريتمنت موداليتيز، النيو تريتمنت موداليتيز.
Just a comment about what was discussed earlier. IVF is very expensive. I do not do it in the US. We don't do it in the US unless parents wanted to do it. It costs like $16,000, $20,000 and it's not covered by insurance, so it's not done routinely. They don't do abortion. Usually, most of my families don't do abortion because we have a lot of treatments for CF, so they're doing really well. The prenatal diagnosis is also done. Really, a lot of the time is not done. So because the parents would say, well, I'm not going to have an abortion, why bother and why, cause miscarriage. We do, what I really think is needed in Egypt is newborn screening to be widely used across the country, not pilot. The pilot that we have here is not very good. So I think the answer is newborn screening because that would lead to a registry. Because I really don't think abortion is what I would aim for, even here.
ولازم نطالب بقى ببروجكت كبير زي بتاع الثايرويد يقدروا فعلا يعملوا
Exactly. Yeah, I'm working with the Ministry of Health. They've been very receptive. So really, the next step is to expand it to, my major thing with Ministry of Health is to get the sweat testing equipment here because the ones we have here is very, very old. And we really need update to that, so upgrading to it. So we're working on that, and Dr. Nadine is going to help me to get that done. We have a lot of prospects that we can work on. So there is a lot of things that we be doing in Egypt. Inshallah. So I changed the title a little bit because I really wanted to talk about the treatment of CF and also to focus on. I didn't want to keep her standing because I really wanted everybody to be aware of the modulators and what we're doing recently for CF. So I don't know if that was mentioned earlier, so if I'm repeating, I'm sorry. But CF is then known in the dark ages or middle ages, like if you kiss your kid and the kid is salty, then they're gonna die before a year of age. So that was the German folklore, and since then, some parents actually now even neglect their kids and it's like, oh, my kid is salty, test them, and we test them and they don't have CF. So not automatic. But in 1905, that was the first time that an Austrian physician described meconium ileus. Nothing happened after that. Then Dorothy Anderson is really the one that did the autopsies on babies that died of CF and found out that the lung, there is a lot of cysts in the lung, a lot of fibrosis in the pancreas. She called it cystic fibrosis. In the US, we still call it that. They, of course, have to change the name because they have to change the name, so they call it something else. And then, okay, we knew that CF is like she described it, but how do you diagnose it? It wasn't until there was a heat wave in New York City in '48, and they realized, because they didn't know what the nature of the disease is, then we realized that there is a lot of, like, the sweat are very salty. There is a lot of chloride, sodium chloride in the sweat. Again, nothing happened until about the late 50s when Gibson and Cook came up with the sweat testing. So officially, we didn't start testing till the late 50s. So a lot of families come to me and say, we don't have family history of CF. Yes, because it's recent. So the grandparents and things like that would not be diagnosed. So it is an autosomal recessive disease, as you know. It's the most common in Caucasian, but it affects everybody around the world. So there is this paper that Maggie showed, and I might have it in there too, is really looking at CF around the world. It's everywhere. No country have no CF. Everybody has CF. So the estimation is, well, in the U.S., it's 1 in 3,000 births, and that is a lot. Like Dr. Trump said, in Egypt it's 1 in 2,600. So that's why I think it's way overestimation. So in the US it's 1 in 3,000. We have now actually the 30,000 patients, now they are 40,000 because they're living longer. So it's not that we're discovering others, but they are living longer. So we have about 40,000 right now. The adults are more than half of the pediatrics, so again, they're living longer. And worldwide, this is an estimation of 70,000. Now there is a new estimation, it's 140, and I think by the time every testing will be done, will be a lot more than that. CF affects all organs in the body, mainly the lungs, so that's why pulmonologists take care of CF patients, but as you can see, it affects everybody. And it's a process that starts with the defective gene, abnormal CF gene, and then you get into the dehydrated mucus, and then you get into infection and inflammation. So I'm not going to focus too much about what I treat with right now, because I want to really talk about the modulators. So right now, I have a CF patient coming in. I have newborn screen. They come to me. The baby is absolutely normal, no problems yet. And what I usually start with bronchodilator. I usually do it twice a day, and we do it either inhaler or nebulizer according to what the parents want. And we teach them how to do physiotherapy. That's why our Chris Tapley, our physical therapist, is very important part of the team. I mean, all of them are, so not very in trouble. But yeah, he comes in and talks to parents, teach them how to do it. Then we, if they get sick, then I add the mucolytic. I don't add mucolytics automatically. If they start having infection, I will do the mucolytics, which I have pulmodine, you have N-acetylcysteine. Then we do hypertonic saline and antibiotics if they have infections or if they start having pseudomonas. We encourage exercise all the time. And this is just to show you at a glance, so we start with inflammation, and that leads to obstruction, that leads to infection. Some people believe that it starts with infection, but either way, it's a cycle. For infection, we have tobramycin, we have garamycin, and we have amikacin. It's okay, you can use that. We have astriana, we have colistin, which you have here as well. And we do vancomycin nebulized, and I think Dr. Iman contacted me one time, and we did it for a patient here. The obstruction, we have airway clearance in addition to the bronchodilator, the glutamate alpha or the N-acetylcysteine, the hypertonic saline. Mannitol is approved in Europe and in the US. I don't use it as much because I have hypertonic. They're very similar in the action, so I usually don't use. I don't think I have anyone on mannitol. And then the inflammation, we have the Vitromax, which we do here, use it, and it's not an antibiotic use, it's an anti-inflammatory use. Ibuprofen has been studied, but we don't use it because you have to have very high dose and you have to. The inhaled steroids, I use it only if there is asthma component or if there is ABPA, allergic bronchopulmonary aspiration. So that's kind of like what I'm doing now. So I'm moving to the modulators because I think that's the excitement in the CF world right now. So this is the gene. So you have the gene is like consists of 6 nuclease spanning domains, and then you have the the R, or the regulatory domain, which supposedly not having any mutations in there, but it does. And then you have nucleotide binding domain, 2 of them. And F508 is in the first nucleotide binding domain. You can see this is in the cell surface, and this is inside the cytoplasm. So it's the chloride channel, or the gate, if you will. So this is controlling the chloride going in and out. And that was very important to make us understand the modulator. So the first one they looked at is the class 3 mutations, which is mainly, and I'm going to go over that in a little bit. Normally you have the CF gene, normal CF gene, start in the nucleus, goes out to Golgi apparatus, it gets vented, go to the cytoplasm, go to the cell surface, control the chloride in and out. In the class 3, you have it produced in the nucleus, go out to the Golgi apparatus, go to the cell surface, then it doesn't work. So we call the gate is broken. So we usually need something to make the gate work, kind of thing. So the first modulator was ivacaftor. So ivacaftor was studied. We usually, in the US, with any drug that looks promising, they study it first, and then if it looks good, then we do phase 1 trial to see is it going to be harmful for patients or not. Usually they try it on normal patients, normal kids, normal adults, and then CF as well, to just make sure we're not going to cause more trouble. Class 2, phase 2 trial is mainly looking at what dose do we need to use. So we know now it's not harmful, everything has side effects, but can we move on? So we did phase 2, and then phase 3 is when, over the country, hundreds of patients were included. So you have, the results were amazing. We actually were one of the centers that did it, and it was very, very exciting to be part of it. So you can see that when you look at the sweat test, it went down to normal range, to below 60. And then the lung function improved by about 10%. The exacerbation rate went down, and also they start gaining weight. We didn't know that. We didn't know that the weight is going to be improved as well. So it did. So we're very excited. So that's great. We're very excited to have phase 3. It actually applied to phase 4 and 5 as well. But the number of patients was about 5% that we're covering. So the goal is to go to be able to get to class 2. This is where the delta F508 is. This is the most common. Class 1 is a nonsense mutation. This is when you have mutations that have accident. And that one, the modulator doesn't work on. We're trying to see unless it has another mutation that qualifies. So that class, there is a lot of work going for it. Class 2, and the problem is, here you go, the nucleus. So the gene is done here, goes out, goes to the Golgi apparatus, goes to the cytoplasm, and gets misfolded. And it cannot go to the cell surface. So the problem is you want to have it, the misfolding corrected, and then you have it to go to the cell surface and work. So 2 problems we have with class 2, and then these only need the ivacaftor. So the misfolding, you need something to correct the misfolding, and then you need something to potentiate it. So the ivacaftor is a potentiator that's all class 3, 4, and 5 needed. This class needs both of them. So the first part was, okay, we're gonna, ivacaftor is fine, it's a potentiator that's gonna be used, we're not gonna worry about it, but what is the corrector that we're gonna use? So they did the first corrector, and that was the lumicaftor. The lumicaftor wasn't very exciting, and I was talking to Vertex, and I said, you're a victim of your success, because the ivacaftor was hugely improved, and then you have this, which practically you have 2% improvement, which is really not significant. So that I've used it till we got something new, but I wasn't putting everybody that qualifies on it because I wasn't seeing that much improvement with it. Then the next generation of correctors came, which is the TED catheter. That was better. We have improvement, but only 3-4%. Again, not very exciting. And then when you have an overlap, to just show you the difference between the IV catheter, see how much improvement you have, versus the TED catheter, IV catheter. So lots of work needs to be done. So this is just to show you the timeline of the ventilator. So what happened is the FDA in the US, the Federal Federation for Drug Administration, takes a long time to approve drugs. So you do the study, it takes about 10 years to do studies. Then you go there and you're blocked there for another 5 years to look at the data, and you should. CF is an orphan disease, so things will actually move faster. So the studies were not taking 10 years, it was probably taking 5-6 years, because that was the only thing we have going. So recruited patients very quickly, and our CF patients in the US are very willing and very happy to do studies. So they just tell us we're going to do it. It was approved real quick. I think it took maybe a couple of years maximum. And the CF Foundation is very supportive. They went to the FDA meetings, patients went and they were crying, and lots of action. So it got approved real quick. And then that was approved in 2015, 2018. But again, IV catheter is great, but how about the others that are not as good? So maybe the way to think about it is, if you have one corrector that's not good enough, let's have two correctors. Are the two correctors going to be better to augment each other? And that's where the leap of the triple combination came. So there was a elastic catheter, which is a new corrector, in addition to the TISI catheter and then the IV catheter. So we had the three of them. They were studied, and the good thing is they were studied in Europe, Australia, and in other countries, and in the US at the same time, so we can get the approval from the FDA and the European authority at the same time. So, and the results were amazing. So this is the result. I mean, you can't ask for better than that. So the primary endpoint with the FEV1, we got improvement by about 15%. The sweat testing went down to 40, even lower. I have patients with 20, sweat testing, sweat chloride. So that was very exciting. This is a tricatheter that you have here in Egypt now. And then the quality of life, the CFQR, or the quality of life questionnaire, patients, of course, felt much better on it, so significantly better. And they also gained a lot of weight on it. Right now, we have some problems with, patient gaining too much weight. So Stacy, our dietitian, not only works with them for the people that don't gain weight, but she works with the people that gain too much weight, which we never heard about that before. So she tried to get them to slow down in the snacks. CF kids usually come to the middle of the night and eat ice cream and cookies and all. Slow down, we should not do that. But here, yes, let them keep it. So it's very effective, very great, and when it was approved for 12 and above. Since then, they reduced it to 6 and above, now it's 2 and above. And for the younger people, we don't really need to do effectiveness. We just need to make sure that, not harmful for them. So it's safety more than effectiveness. So this is having like the one I showed before. So you have here the IV catheter. You have the TISI catheter, IV catheter, which I don't use anymore. And then you have the triple combo. Triple combo, we don't need that tricatheter. We don't even know how much improvement will continue. Patients have been coming in, the improvements are so significant. One of your kids here, 25-year-old patient, he's on 2 liters of oxygen. He wasn't able to walk too much without stopping. I'm using him because I just talked to him. And a lot of examples in the US as well. He went from 2 liters to a liter to now room air during the day and 1 liter at night. He said he's able to work 8 hours a day, and I'm like, really? And he actually said that last year he wasn't able to fast, maybe 1 day or something. This year he fasted 2 weeks. So I'm like, very impressive. And you have examples like, that's why I'm like, send your patients. I need patients to be on tricatheter. We have it, it's free, get it for them. And this is what I have in the US. So this is just to show you how we work. This is CF patients with up modulators, and they end up dying young. The median survival before the modulators were like in the 20s, 30s. Now our median survival is 60 years old. So that's what I want to see in Egypt. And we can achieve it if all the patients that qualifies are in Tricanada. These are two of E.U.P patients. So there is a new modulator that I just want to cover it so you're aware of it. I'm not asking for it to come to the US because it's not worth it. It's as good as Trikafta. So why bother? Let's just stick with one. And the difference is that the Trikafta is twice a day, and the reason is that the ivacaftor is shorter acting, so it's every 12 hours you have to take it. So the other two are 24 hours. So you have to do it twice a day. So can we do once a day? So they had a different combination of medications in it. So the Benzicaftor is the new one they added instead of the other one, then the Tizicaftor, and then this is the deuterated ivacaftor. So they got the ivacaftor and made it longer acting. So it's done daily, once a day. It's approved for 6 years and above. And this is just to show you all the modulators that we have in the US. Mainly I use a lot of Kalydeco, not a lot because I don't have a lot of patients that qualify for it. Semdeco, we don't use that much anymore. Well, we use in some patients, and some patients actually feel better on it. So I have few patients on Semdeco, which is, been used as well. The Orkambi, we use not as much. Everybody that qualifies for Trikafta is Trikafta. Whatever you're on, I'm switching you because I see the benefit. Except one that really likes Semdeco, I kept her on. Then the electric, the new ones, the Benzicaftor, the Tizicaftor, and the deuterated or the deuter ivacaftor. Yes, it's once a day, but is it adding any benefit? Clinically, we don't see that. It's comparable. But there's extra 31 mutation that qualifies for it. This is how it looks in the mechanism of action. Benzicaftor is a novel molecule with the protein binding that similar to so it's really very similar to the Tizicaftor. So clinically, again, we looked at the data and it's very comparable to Trikafta. The major difference is that it's once a day and there are 31 mutation extra that qualify. Side effects, we compared it to the Trikafta and it's very similar side effects. The recommendation is for starting Trikafta or Electric is to do the enzyme, the liver enzymes once a month for 6 months, and then every 3 months for a year, and then once a year after that. The idea is to make sure liver enzymes are in good shape. You have to do the eye exam for patients less than 18 years once a year to make sure there is no cancer. So now we have 4 of them. So the future is, that's all great, but how about class 1? And class 1 are all the patients that cannot tolerate Trikafta or have side effects from Trikafta. What do we do with them? And there's a lot of work going on for that. So there's something called the RNA-based therapy to see if we can do the tRNA for the nonsense mutation, mRNA for mutation agnostics, but they know that we don't know classes-wise, and antisense, oligonucleotide, and then also gene therapy. So gene therapy has been worked on since 1989 when the gene was identified. We're still working on it. So I'm not holding my breath. I'm really mainly very interested in the modulators right now. And there are several companies that are working on it. This is the therapies from the CF Foundation. CF Foundation is very active very supportive. Actually, they support our work here. So I'm coming in with their support and my team. And you can see that there are studies going on with the CF modulator. So we don't want only to be Vertex working on it, we want other companies. We have working on the restoring of the surface liquid, mucus alteration, anti-inflammatory, anti-infective, and nutrition as well. So they're working in all directions, and they are very supportive of any research we usually submit to, any good research. This is the median survival. So you can see here, this is when the CF was identified. They were dying before a year of age, and then gradually got much better. Right here in the late 60s, the CF Foundation was established by families, actually. And since then, they've been very supportive. It's a pleasure to be an accredited CF center. So every center in the state works to be accredited. So very important for us. And then you can see that there's lots of development here in the late 80s and 1980s. With Palmozine coming in the 90s, the Toby coming in the 90s, and then hypertonic, and then now the modulator. And look at this, it's a straight line up. And it's actually in the 60s, the median survival. So we did a lot, we've been through a lot through the years, and we are looking forward for that to be here as well. I don't want to see the malnourished children here, which I'm still seeing. I wanted them all to be treated. So work with me, let's get patients qualified on for Trikafta, to be on Trikafta, and let's get them back. So thank you very much.
Thank you, Professor Samya, for everything, for this lecture. Actually, maybe 2 or 3 years before we heard the names of all these gene modulators, we are thinking that we are, just imagine. Now we have one of them. But my patients belonging to type 1 who have no protein. All our patients now are acquainted by the type of the gene problem. So they are keeping asking, any future hope for those patients? Type 1, which have no protein.
Well, like I presented, they're still working on it. I think most of the patients here are the Delta F508 incidence is actually 57 to 80. So the slide that Maggie showed is actually outdated. My data now, because I'm writing a paper about the mutations that all of you, whoever mutations will be on it. The incidence is about 57%. There is a lot of other mutations that qualify. Let's get all of them with Trikafta first. Then I would worry about, Dr. Mona was talking about rare mutations. Let's talk about the common mutation. Let's get everybody that qualifies in it, taking Trikafta. And then we'll talk about the rare mutation, we'll talk about the class 1 mutation. But class 1, right now in the US, we don't have anything for them. They are doing studies, they are included in studies, but nothing else is available.
Thank you very much, Samya, for your illustrative, informative lecture. And second, for effort with your team, for education, and for caring for cystic fibrosis in Egypt. Thank you very much.
You're welcome. Thank you.
Now, it's my pleasure to introduce Dr. Iman Hoda and Dr. Contribution and cystic fibrosis care in Ain Shams University.
صديقنا بتاع الكمبيوتر شغال ده الحسن
سمير خلاص
بصي لو عرفت تفصلي بين المحاضرات